Thank you, Dr. Ogden. Next, we're going to hear from Dr. Ann Bullock from the Indian Health Service. Dr. Bullock is Director of the Division of Diabetes Treatment and Prevention at IHS. She will be speaking to us today about the prevalence and trends in obesity in American Indian and Alaska Native populations. Her bio and all the bios for our terrific speakers are in the briefing materials, and so we're not giving more detailed bios. But now let me join me in welcoming Dr. Bullock.
I'm thinking that's our physical activity, right? Great. Well, thank you, and it's an honor to be here and an honor to see Dr. Kamenika again after serving on the committee, and Dr. Chin. Actually, years ago, we were on what we used to call the IOM, right? Okay. So the one part of my bio that I will add is that I'm an enrolled member of the Minnesota Chippewa tribe, so I'll often use the term our or population to be inclusive of myself. And we'll be talking about a population that is generally not included in national surveys, as we'll talk about. Dr. Ogden showed one slide where there's some American Indian Alaska Native data, but even in those types of surveys, it may or may not be representative of Native people generally, even when there's enough of us to break us out as a subgroup. So nothing to disclose. These are my own views, and I'm going to show a couple of graphs from our paper on childhood obesity and had permission to do that. So for those of you who are not familiar with the Indian Health Service, we're a full member of the Department of Health and Human Services, but we're often the one that people aren't familiar with, along with NIH, CDC, HRSA, and others. At IHS, we serve members of 573 federally recognized tribes in 36 states. There are 2.3 million American and Alaska Native people served in this way. And IHS is not the only one to provide health care in this system. We have IHS Tribal and Urban, we often call ITU. IHS provides direct care, so actually federal facilities providing direct care. We're one of the few federal agencies that actually does provide health care. In addition to the VA, the DOD, Bureau of Prisons, there are actually very few of us actually that provide direct health services, HRSA, by funding the community health centers, but not providing it directly. The federal system encompasses that. Tribes, however, have the right to assume, through self-determination, control management of their programs. And over 60% of what is appropriated to IHS each year is actually managed by tribes in this way. And there are 43 urban Indian organizations that, as you might guess, work in urban areas where there are large Native populations. So data sources, do want to just mention this briefly. So as discussed in the National Diabetes Statistics Report, we're usually not sufficiently included in national surveys due to small population size, definitely not in NHANES, even a little bit, as you showed in NHIS and BRFSS. So we often cannot do Native American specific estimates. We can't get those from the same data sources as other population groups, and so by definition we have to use different data sources which have a little bit of apples and oranges to them in terms of their sources, and they each has their own strengths and weaknesses. So overwhelmingly what we often use is the Indian Health Services clinical database. So this is health-related, clinically related data submitted to the IHS National Data Warehouse by IHS tribal and urban facilities across the country. So it has the advantage of size, distribution, and actually another one, which is that, interestingly, not only are health issues self-reported in other than NHANES national surveys, but so is race. And that's different for us as well. That for race ethnicity, it's self-reported in national surveys, whereas for our population, we must meet eligibility requirements, which almost always is membership in a federally recognized tribe. So therefore, it has a historical context to it. It is called a certificate of degree of Indian blood. It has other connotations for that it's not self-report. You have to have that in order to receive care and therefore to be in our database. So not only is race not self-reported, neither are the conditions, because they are directly measured as part of clinical care. So that's some big differences. So we use large clinical database. On the other hand, it's not, sample size in that way. It's who comes to our facilities. So this is from the National Diabetes Statistics Report from 2017, the most current. We are the bars on the left. This is diabetes prevalence, then obesity. And as you can see, this is by male and female gender, that we have the highest prevalence of diabetes, as has been known for a long time. What people don't really pay attention to when they look at data like this is where do the data on Native Americans come from? Unlike the rest of the populations represented there, which come from the NHIS, ours comes from us, from the Indian Health Service database. So it is not the same data source, but this is how we have been reporting this data for many years, and so at least there's consistency in methodology and application. And so what is the correct sensitivity and specificity for a number of encounters and how you measure that in our system versus how self-report works in the NHIS? There would be no way to know. But nonetheless, that's how these comparisons are made. So obesity in American Indian Last Native people is not well characterized overall. There have been a number of regional studies and other types of studies looking at this, but nationally, truly representative for adults hasn't been published. We have published a paper in Youth in 2017 covering those years, and our key findings there, that while significantly higher than U.S. youth overall, obesity in Native American youth ages 2 to 19 did not increase over the decade studied. We were seeing such rapid increases in obesity and diabetes for back in the 80s and the 90s. We were all concerned we were going to continue to see that. So the good news here is that it has remained stable, has not been increasing, which is similar, of course, to the U.S. population overall. For youth. We did see, as Dr. Ogden showed, on other populations, a bit of an increase in severe obesity and class 3 obesity in youth. And we take it as what we hope to be a good sign is that children ages 2 to 5 had the lowest prevalence, and this consistently decreased over the period studied. So these are from our paper. The top line, I want you all to note, is not obesity or overweight. It is children with a BMI less than the 85th percentile. So most Native American children are neither overweight nor obese. And this is important to remember as we're thinking about disparities, is that the difficulties that lead to different types of health disparities do not affect everyone equally, even though there are many challenges. However, the next line is obesity in our population and overweight, and then from NHANES, U.S. children overall. So obviously our population does have more obesity, but nonetheless is staying very stable. This next slide I think is really interesting. This is not over time. This is cross-sectionally looking at children in 2015 by age. And what you see is that overweight is almost not a player in this dance as you look at how obesity goes across the ages. But obesity and normal weight, or less than 85th percentile weight, are almost mirror images of each other when you look at across ages. I thought it was interesting. We don't know the exact reasons for this. Obviously, around the time of what you would expect to be puberty, we're seeing, of course, that as we see in other populations, a big increase in obesity. But nonetheless, overweight is neither the highest prevalence issue, as in some other populations you see overweight being higher than obesity. But in our population, the dance really, if you will, is between normal weight and obesity as age progresses. So social determinants of health, of course, are going to be a key part of this whole discussion. And of course, as we've already heard, socioeconomic status has been linked to health and obesity disparities. And according to the U.S. Census, Native American people had the highest poverty rate of all racial ethnic groups in 2017, and also very high rates of food insecurity, which of course is linked to things like diabetes incidence. So I want to mention in terms of, not only is it health behaviors, but it's also the actual physiological programming that goes into determining our risk for obesity later in life. This actually starts in the womb, and actually, as we know, even before conception, with some risk factors being programmed in both to mom as well as through things like epigenetics. But one of the early life experiences that that can also help predetermine not only behaviors but physiologic risk are, of course, adverse childhood experiences. And I think we're mostly all familiar with ACEs, the classic study from the CDC and Kaiser back in the 1990s showed clearly, and I'll show just a little bit on that in just a moment, how important it is to look at what's happened earlier in life to figure out what's happened for risk for later in life. So for our population, actually, there were enough of our children included in this. The National Survey of Children's Health included almost 1,500 Native kids up to age 17, compared with over 61,000 white children. And compared to the white children, the American and Alaska Native kids were more likely to experience 2 or more, 3 or more, 4 or more, 5 or more adverse childhood experiences. And these tend to be similar across different studies, not always the exact same list, but physical, emotional, sexual abuse, growing up with a substance abusing, mentally ill or incarcerated family member, parental separation or divorce, ever seeing your mother beaten, and increasingly, and also 2 categories of neglect, physical and emotional neglect, and many are now also including exposure to community violence, poverty itself as a huge ACE itself, and others. So what's interesting is not just that our kids have had more trauma, to use that term, perhaps similar to ACE, but one of the most interesting things I found about this was that when you look just within our population of kids in this study, the kids who had 3 or more ACEs compared to those who had less than 2, there were huge differences in prevalence of depression, anxiety, attention deficit hyperactivity disorder between those 2, and the differences in the outcomes for those: school problems, grade failures, need for meds and counseling. So what's interesting about this is to look at it's not being a Native American kid, it's being a Native American kid who has these adverse childhood experiences, which for those of us who work in Native communities, we look at this through the lens of what's called historical trauma, which is how trauma is passed intergenerationally, and for many populations started with colonialization and other kinds of things that have led to trauma coming into communities and being therefore passed along in the way that happens. And from the original ACE study, we know that for people with ACE scores of 4 or more, these are adults thinking about their childhood, their risk as adults were 4 to 12 times higher for alcoholism, drug abuse, depression, suicide attempt, 2 to 4 times higher for smoking, poor self-related health, sexually transmitted infections, and for physical inactivity and severe obesity, 1.5 times. So seeing how what happens early, looking not only at obesity, but I would also, as I know you all will do in the roundtable, look at it within this context that earlier life risk factors leading on to not only risk for obesity, but for many other of the social problems that we have, the roots being very similar in many respects. So I do want to mention one approach that we're taking in Indian country about these things, so that would be the Special Diabetes Program for Indians, or SDPI. It was established by Congress in 1997 as we were seeing those rapidly escalating rates of diabetes and complications. It started out at 30 million per year and has been since 2004 at 150 million per year. We provide grants. My division runs this program to 301 IHS tribal and urban grant programs in 35 states. So a fair amount of money, not relative to the problem, but relative to existing resources, and distributed across the country. And over 78% of our grantees are working with youth, primarily on obesity prevention or other intervention. We promote comprehensive community-based approaches, including public health, population management, and team-based care, things that allow communities, they get to decide what they would like to work on. So if they would want to work on obesity prevention, they can decide if they want to work in schools, community gardens, traditional dance, whatever it is that they want to work on, they are able to use these funds to do. And in terms of clinical care, they're able to focus on things that are either not reimbursed at all or under reimbursed, like diabetes education and nutrition and other kinds of programs. So with this approach, looking at communities as well as individuals, this compares the availability of services in our communities as told to us by our grantees in 1997 at the start of SDPI, and then in 2013 after we've been going for some years. And you can see a tremendous increase in availability of services because of the existence of these resources, at least in part. This wasn't just from SDPI, but from any source for funds. And one of the many things we try to do is to adapt national guidelines to our population so that they make sense to us. So taking the USDA's My Plate and translating it into My Native Plate. Now, there are many, many different tribal cultures across the country, and you can't just have one plate. So we do have some other options, but here is one here that's showing ways of trying to communicate this regarding foods that would exist in our communities. We're also very concerned about food insecurity. I already mentioned our high rates of poverty and food insecurity. And when you add to it how remote many of our communities are, how difficult it is for them to have access to foods for all the usual reasons of poverty and the rest, but plus the remoteness, what it takes to keep produce fresh in a reservation store that's hundreds of miles perhaps from a large center is difficult and expensive. So we have created a screening tool. It's available on our website where we encourage not only dietitians but other clinicians to download. And the first page I don't have on here, but it shows two questions they can ask to screen for food insecurity and explain why this is important. And then this they can fill out. This is a PDF fillable form that they can then fill out with local resources that are available in their community and how to contact them and something about information related to who can access those, because there's always eligibility requirements. So I'm trying to communicate ways to help people find more fresh fruits and vegetables and other healthy foods. So I showed you that obesity in children is not getting worse, which for us is a good thing. Diabetes prevalence, so going a little distal to obesity, I realize, but nonetheless reflects some of these efforts that we're making in our communities, partly because of the existence of these resources related to SDPI. So for diabetes prevalence, the years of increasing prevalence stopped in about 2011. And in youth, the rise in prevalence stopped about as early as 2006. The Search for Youth and Diabetes study has reported an increase in diabetes in our population. Please check out the non-representative sample used for Native kids. We replied to their paper to point this out in the New England Journal. So if you look at that paper and look at what I'm telling you, our data is much larger, much more nationally representative sample. Much good about the search study, don't get me wrong, but in terms of our population, it's not representative. And then a little further distal yet, I realize, but nonetheless, what can happen in communities when they're given resources and support to make changes, even within the context of poverty and other problems. So this is diabetes-related kidney failure. We published this in the MMWR as part of a CDC vital signs 2 years ago. And showing, in this case, where the black line, we're used to being the line that looks the worst. But in this situation, a 54% reduction in kidney failure from diabetes between 1996 and 2013, a much steeper decline than in any other population group. So something different was happening. We didn't have more resources. We have less, actually. We're somewhere around 40% of level of need funded. Again, all the difficulties with many people living in very remote rural areas, but nonetheless, a significant decline in kidney failure. And if you use the denominator of being just people with diabetes as opposed to the population, our rates came down to very close to the same as whites, which we never thought we'd ever say a statement like that. Diabetic retinopathy, I won't go into the details here, but similarly, you would expect a similar decline. And even though it's not exactly the same data sets being used here, but in 54,000 Native people who participated in our tele-ophthalmology program, it's a telemedicine program, looking at prevalence of retinopathy and comparing to studies published in the 80s and 90s, there was a over 50% reduction in diabetic retinopathy and macular edema. So again, nice improvements. And then ARC just published this in December, the hospital admissions for uncontrolled diabetes in our population decreased 84% from 2000 to 2015. So again, realize we're again distal from obesity, but the ripple effects of things. So hoping that as other kinds of socioeconomic opportunities slowly but hopefully surely come to our population, that we can continue to see those declines in not only diabetes complications but in obesity and itself. And I would say, even more importantly, as much as I care about obesity and diabetes, I care even more about life outcome. I care more about that kids have the ability to bond and attach and to other people in their lives and to find joy and meaning in their lives, which are even more fundamental to this than obesity. And again, with so many of these things having the same roots in early adversity, we need to be looking at ways to improve that, which will also help us to improve things like obesity and diabetes. So key points here as I finish up. We've seen, thank goodness, significant progress in reducing diabetes complications and at least a leveling off of rates of diabetes prevalence and childhood obesity in American Indian Alaska Native people. And the Special Diabetes Program resources and the ability for self-determination at the local level to determine what to work on and how have been crucial to this progress. We have some of the highest rates of poverty, food insecurity, and trauma as measured by things like adverse childhood experiences. And all of these are strongly associated with obesity and chronic disease. And that for us all to make progress here, social determinants, as are being discussed here, and even beyond, must be meaningfully addressed. These are things we can do to some degree within communities, but of course larger policy and other kinds of decisions are key to making a difference in those things. So with that, I'm right on time. Thank you.